Welcome to Home Care Connection, brought to you by the Rutland Area Visiting Nurse Association and Hospice. At RAVNAH, we provide a full range of personalized services that allows our patients to recover quicker in the comfort of their own homes. Many of our patients receive rehabilitative care from our team of physical, occupational therapists and speech and language pathologists. Therapists treat patients who suffer from illness, injury, or surgery after surgery, and they also instruct patients and their families on topics including safety and balance, among other things. That's what we're going to talk about today on Home Care Connection. Here to explain RAVNAH's therapy programs, we have two guests, Jamie Belchak, the Therapy Services Manager at RAVNAH, and Karen Kipp, an occupational therapist with Kids on the Move. Welcome.
Thank you.
Thanks, Harry. I think to get started, I'd like to just there are three main types of therapy that RAVNAH offers. Perhaps you could just tell us a little bit about the three types of therapy and the types of treatments that each provide.
Well, the three therapies that we provide at RAVNAH are physical therapy, speech therapy, and occupational therapy. Basically, physical therapy, occupational therapy work on function, and speech therapy works on cognition as well as swallowing. Physical therapy in the home, a lot of times we look at how the home environment's set up. We look at how safe the patient is in their home environment, walking around, getting on and off of surfaces, in and out of bed, and functioning in their home environment. Occupational therapy, which Karen is an occupational therapist, they typically work on how the patient functions with their activities of daily living in the home, getting dressed, bathing, cooking, as well as in moving around that environment safely. And speech therapy typically works on cognition and speech issues, whether it is speaking, understanding the spoken word, swallowing and chewing foods, swallowing and chewing, or swallowing liquids, and executive functions like potentially working on checkbook balancing, that type of thing.
Wow. It's a pretty broad range of services that the three provide.
Yeah.
For the purposes of trying to understand how each of the three might be used, what are some common referred diagnoses for each of the three therapies?
Well, let Karen start, and I can chime in if you'd like.
Well, I work as a pediatric therapist, and I also work in the adults at RAVNAH. So as far as the pediatrics goes, we see a lot of children with developmental delays, children with autism or autism spectrum-like disorders, some more of the physical disabilities like cerebral palsy or torticollis in the infants, but and then with the adults, the population that I see are a lot of people recovering from surgeries, whether it be a replacement of a joint or just some general deconditioning. Just people who may have had a fall or didn't admit to the hospital and are just coming home and kind of checking on their safety and their abilities to perform their activities of daily living.
Thank you.
Yeah. In physical therapy, our typical patients in home care, we see a lot of joint replacements, elective surgeries. We also see a fair amount of people who have chronic conditions like diabetes, congestive obstructive pulmonary disease, which is commonly referred to as COPD, CHF, heart disease, and we work on conditioning, strengthening, and improving their function. Very oftentimes we will see patients that have cognitive issues like dementia, and we help train the patient and caregivers on appropriate techniques to stay functional and stay safe while in that disease, during that disease process.
Mm-hmm. And speech and language pathologists are, their typical patient is sort of stroke patients and...
Yeah, they see a lot of neurological
Yeah.
impairments, strokes, and the ramifications from strokes. A lot of times people have difficulties either expressing themselves or acknowledging what other people are expressing to them,
Mm-hmm.
so like receptive. They also have difficulty with word finding and pronunciation of words, so our speech therapists work to improve all those mechanisms, the word findings, the receiving of speech, and the production of speech.
You know, before we talk about the specific types of treatments that we provide directly to patients, I also understand that in particular in physical therapy, we do basically home safety analysis. Is that right? Is that the right?
Yeah, a lot of times we get referrals from a variety of different mechanisms. Someone can have an injury and they go to the hospital and they get out and we get a referral. Someone can have an elective surgery, we get a referral. And then there are times where patient may be having some more difficulties at home, at their home, and they express this to their doctor or even a family member. And the doctor says, well, you know what, I'd like a therapist to go out to do a home safety evaluation. So the home safety evaluation, we would go into their house and we take a look at how they're functioning in their environment, what type of environment they're in. Do they have stairs that they have to use? Is the bathroom accessible? Does it have grab rails? Is the bed at the appropriate height for them to get on and off of safely? Are the chairs appropriate for the patient to get on and off of safely? We look around at the actual structure of the house. Are there smoke detectors present? Is the flooring appropriate? Are there throw rugs or scatter rugs about the environment? And we try to make recommendations and adaptations to the home to provide a safer environment. So sometimes we ask, with the patient, we talk to them about the safety issues, and we make some recommendations: removing throw rugs, changing the bed height, adding a grab rail or even another handrail to a staircase, improving lighting in the house, adding night lights. So all those things tend to provide an environment that is a little safer, that'll help prevent a fall in the future or any difficulty. With occupational therapy, sometimes we even go about changing the environment a little bit more radically, adding grab rails that are bolted to the wall or into the shower, adding a shower that's accessible, that doesn't have a lip on it so that you can walk right in, getting a toilet that's higher in height so that it's easier to get on and off of.
And for our patients in particular in home care, and even if they aren't our patients, but it is an individual who may not necessarily qualify for Medicare or Medicaid services, but for whom we are providing one of these home safety analyses, they really, the value of something like that could simply make my home safer to live in and for me to remain independent. Is that fair?
Yeah, that's correct. A lot of times when we're in that environment and we're looking at making the home safer, we find some issues that might be addressed with some strengthening or an exercise program too. If someone's having difficulty going up and down the stairs, we can put another handrail on the staircase, but that might not solve the entire problem. And so when we do our home assessment, we're also looking at the person as an individual. Are they weak? Do they have a balance issue? And if there is those issues that arise, or those problems, we can contact the doctor and say, hey, you know what, we saw this, and we'd like to work on an exercise program or a strengthening program or a balance program with the patient.
So for no matter what, regardless of the type of therapy that is being provided, all of our patients come from a physician's referral?
Well, actually, we do need a physician's referral to treat a patient. But a family member can refer a patient to us. They can call our intake line at RAVNAH, and we can assist them with getting in contact with the physician to get the actual medical referral. We do need to treat the patient under a doctor's order, but anybody can make a referral. If a caregiver or a patient's family member sees some difficulties with the patient or difficulties with the home situation, they can give us a ring, and we'll be able to point them in the right direction, getting them in contact with their doc, and we can even, you know, inform the doc of what information was relayed to us, and possibly get out there under a doctor's signature and go out and see the patient.
And once there has been a referral and once we've accepted a patient, what can a patient expect with respect to the type of treatment that they receive, and how is a general, what are the general types of, what does a general treatment plan look like, and or what are some of the differences between sort of routine treatment plans?
For occupational therapy, you usually start with, for both the pediatric and the adult clients, we usually start with an evaluation. With the pediatric clients, sometimes getting some background information as far as maybe a recent a test done by a neurologist or other specialist, talking to the parents and potentially teachers to see what the child looks like, depending on the age of the child, if they're in school or if they're not. So, and at that, having that evaluation actually drives a treatment plan as far as developing goals. With pediatrics, a lot of the goals are family-driven, you know, what the parents would expect their child to be able to do, or if the child's old enough to advocate for themselves, what, you know, goals they have. And similar to the adult caseload, the patients, you know, come in and have a referral and kind of do a broad assessment of all of the areas in their environment as far as their ADLs, activities of daily living, basically taking care of themselves, and their instrumental activities of daily living, taking care of their home environment, such as meal prep, or potentially taking care of another person in their home with their caregiver to that person. And then after the evaluation, being able to say, well, you know, what kinds of things are maybe you lacking at doing for yourself, and what would you like to get back into doing, and really they drive the treatment plan, because you discuss with both the patient and with their doctor as far as what goals they would have, and then basing the treatment plan, you know, as far as how many times a week or for how long, and what kinds of, whether it be a strengthening program or if it be an educational program, as far as educating them with some of the things that Jamie said about safety within the home, and,
Sure.
and a lot of preventative kinds of things, and general fitness for the adults, and getting them back into, if they, you know, maybe they are having trouble with getting in and out, or transferring in and out of the shower, and just making some, you know, a treatment plan around that, as far as, you know, do they need some equipment, or do they need some strengthening, and working, the OT works with the physical therapist, and I do work with a couple of speech language pathologists as far as making sure that that is a cohesive plan of care and treatment for the patient of ours.
Sure, that makes sense. And could you just take a minute or two and just tell us what activities of daily, what are some examples of activities of daily living that an occupational therapist?
Well, activities of daily living is a term, like an OT term, but it's just basically how you function in your day-to-day life, things that you do, whether it be, you know, bathing, dressing, you know, making your meals, feeding yourself, being able to manage your medications, being able to, you know, take care of your home, whether it be picking up things, whether it be feeding pets. Some things, sometimes occupational therapy touches on some of the overlapping things that speech therapist does as well, as far as the money management, you know, remembering to take their medication on a certain time, some more of the cognitive aspects, and also a big area of an activity of daily living would be, you know, like a work or leisure pursuit. Maybe especially for the adult clients that maybe they've are retired and they're, you know, doing some volunteer work, but they can't, you know, perhaps do all of the things in the capacity that they used to, but,
Right.
you know, maybe giving them suggestions as far as modifying, or, you know, maybe they used to do knitting or crocheting and just as a leisure pursuit, and just getting them back into participating in some of those other areas of their life.
So in an occupational therapist plan of care, dealing with activities of daily living, everybody probably has some similar ones, like eating, dressing, like that, but then there are patient-specific ones that are important to me because I want to get back to being who I was, and so you would work on both the sort of common ones, but also the patient-specific ones.
Right, and I think that, you know, that's how you drive your treatment plan, and, you know, developing goals with, you know, your patient, between the therapist and the patient, and the therapist and the doctor and the patient, that triad, as well as the other therapies.
Yeah.
But because it may not be important for you to put your own socks on because you've always had your wife do it, it may be more important that you're able to transfer in and out of the car because you know, enjoy
Driving.
You know, driving.
Yeah. Good. And so physical therapy then.
Well, I think it's important what Karen says about the plan of care and how it is not only patient and treating therapist coming up with a game plan and goals, but also that patient, that therapist, and the entire team, the other therapists involved, getting around and forming those goals. I can tell you, for instance, I had a patient about a little over a year ago that her primary goal was to be able to get back out into her dairy. They own a dairy farm, and she wanted to be out and among the cows. And so, from the physical therapy standpoint, that was one of our goals. We needed to get her so that she was able to walk and get out to the barn, and be able to get there functionally. The occupational therapy part that played into that was that when she was out there, how could she tend to those cows? And so our occupational therapist worked with her on getting, opening and closing some of the corrals, and getting the cows to, she wasn't actually doing the dairy, the milking, but she was helping out with feeding and moving the cows about in the barn. And so the occupational therapist worked with her and came up with a routine that worked with her limitation to be able to tend to the cows and to take care of them. So together as a team, we got her to her ultimate goal.
And that team concept, which clearly is one of the trademarks of home health, is having an entire clinical team with therapists and nurses and home care aides and the like, is really an important piece of the whole puzzle, because we really are treating the whole patient. It's not just one sort of isolated symptom.
A lot of patients think, okay, I'm going and I'm having my knee replaced, and they're going to come out and they're going to work on my knee, and they see this knee as that's what I need to get better.
Right.
When we go out, we explain to them and come up with the plan to get the person better, to get the person functional, and the knee just happens to be something that we might have to pinpoint on, but it's that function, that return to function in their environment. In home health, it's really important that we try to keep the patient home, or try to get them to the optimal level of function in their home. And so, as their therapy continues and they're able to do more, they might need some refinement, and at that point they would be graduated to like an outpatient physical therapy or occupational therapy setting. But when we go to the house, it's to treat the whole patient.
And, I heard earlier the word goals used, and it strikes me that in the various therapy services, the goals of the patient or the goals of the plan of care, it seems like a fairly important part of the overall mix. Perhaps maybe you could just tell us a little bit about role the goals play, and how is it an important part of a plan of care?
Oh, it's a very important part. You know, the doctor has a goal, the patient has a goal, we have a goal, and we all come together to form the global goals that we'll set out to achieve. And those goals very often involve function. In today's society, we want to show a patient that is getting better and is able to do more functionally. So I can take someone's knee and I can make it strong, but if it can't walk, if the patient can't walk, well, what good is the strong leg? So we develop goals that are very functionally oriented. You know, people are going to be able to walk. They're going to be able to go up and down stairs and get on and off of that low sofa that's so comfortable. And we take those goals and we work on things that need to be addressed to attain those goals. So that might mean strengthening the lower body, improving balance, and take it down, break it into pieces, work on those pieces, and then you can attain that goal. So, you know, we develop our plan of patient, we set our goals to the doctor reviews those, and he may have some suggestions, and he signs our order, and then we go about doing our work, getting our job done.
And when those goals are established, the patient's family, are they a part of the goal-setting process?
Yeah, very much so. You know, when Karen was saying we get a little history from the patient, we find out what they were able to do before, what they want to return to doing, and then we come up with that plan of care. And it's a verbal interaction, and it's a continuously, you know, we change it as need be, but we talk to the patient about, okay, I see that you want to get back out to the barn, so this is what I can do to help you achieve that goal. And then we put it in writing and we send it to the doc. As they get better and they start achieving those goals, there comes a point where you know, you are basically graduating from either physical therapy or occupational therapy or both, and hopefully it's because you've met your goals. Many of the providers will pay for physical therapy and occupational therapy services, providing that we do have functional goals and that we're making strides to achieving those goals. Now, let's say the goal is, you know, the patient wants to be able to skydive again. Well, that's a goal. That's a great goal for a patient to have, but it may not be functional enough for Medicare or any of our other payers to think that that's relevant. So, you know, we do have to develop a kind of a set of goals that are both relevant and achievable.
And you know, that it strikes me that what would be a relevant goal is probably, to a certain extent, predicated on what we're actually treating the patient for. Meaning, you know, we treat sort of people recovering from surgery, as well as we also treat people recovering or people dealing with chronic illness. And perhaps maybe you could just talk a little bit about the difference between the types of plans of care that might be used for a person recovering from surgery as opposed to somebody dealing with chronic illness.
Someone who's recovering from surgery, obviously, it's an invasive procedure. You know, we see a lot of patients that have gone through the total joint replacement program at Rutland Regional Hospital, and the program is very progressive these days, and they're using a minimally invasive surgical technique. So they're coming out back home sooner, and they're becoming functional sooner. So the goal or the plan with a patient like that is to get them get their range of motion, get their strength, get their swelling down, make sure that their incision heals appropriately, and to get them functional in their home, and then they typically will go to outpatient to finish up with their therapy needs, and become, you know, get that limb as strong as the other limb. Someone with a chronic illness like COPD or CHF or diabetes, they may have had a hospital stay because of you know, an exacerbation of that illness. Whenever somebody's in the hospital, they tend to spend a lot of time in bed, and they may get weak or have some difficulties moving around their environment. So when we see that patient, again, we're working on strength, balance, safety. We may not be pinpointing a certain joint or certain affected limb, it may be more of an overall strengthening or say balance program that they're on. But the same thing, working on energy conservation, gaining strength, gaining endurance, getting around their environment as safe as they can, providing the appropriate device to get around the environment, whether that be a cane or a walker, or graduating to using no assisted device.
I know I've heard this term before, phrase before, in dealing with home care patients, is that discharge planning starts at admission. I wonder, is there a normal length of time? Is there a regular length of time that we treat patients? Is it dramatically different, or is there usually a sort of general time frame in which services are provided?
Well, I know in the pediatric realm, a lot of the kids have a diagnosis from birth, and it's not like they were born with all of the things that they needed to be able to do, and you're getting them back into doing them, similar to the adults.
Right.
The adults knew what they were able to do, and they are able to verbalize what they'd like to get back to doing, where in the pediatric areas, it's really about caregiver training and teaching the parent or the caregiver to provide or set up these activities for the child. It's not something that's going to take, some pediatric patients can be on your caseload for years.
Sure.
But it's more like you're going in to give them instructions, like if, for instance, the child has some speech issues and they're not able to express their wants or their needs, maybe going in and giving the parent some suggestions and kind of stepping back and letting them continue with that. And I think that it's really dependent on the caregivers, and it's dependent. I know a lot of with the adults, if it's like a degenerative kind of dementia, that it's not or similar, that has a progressive nature to their disease, that it's really a caregiver training. So it might be something that's a short term versus like a longer term.
Sure, that makes sense. And in physical therapy and
yeah, I think there is no golden rule to how long someone's being seen for physical therapy. We are, our acute joints and like, we typically see until they're no longer homebound, where they can get around functionally and are able to go out to outpatient services to finish up their therapy. But many times with our diagnoses like the COPD or the dementia or things that may tend to be progressive, we do a lot of patient and caregiver education to help the patient and the caregiver deal with the tendency for remission and a rebound. So it really varies on how much time we spend in the home based on the needs of the patient,
the specific needs of the
ability of the patient.
Which makes sense. I mean, we have only about a minute of time left. I was just wondering if you could, around that time, how about a difference between receiving physical therapy in my home versus physical therapy in an outpatient? Is there much of a difference between the two?
Well, I think it's part of the continuum of care. Someone who gets sick or gets ill and ends up in the hospital has therapy in the hospital. They may come home and they're a little bit debilitated, so it's a very taxing effort for them to leave their home. They might have some difficulty walking, or they're just so fatigued that at the end of a treatment session, they wouldn't be able to get into a car, go to a treatment session, come back home.
Right.
So we typically take them through that period, that transitional period where they're too well to be in the hospital, but too ill to be going out and about in the community. And we try to get them to the point where they're able to function as a community member and function in the community. And they can then go to outpatient services and finish up getting stronger at the outpatient level.
Thank you. Our time is up. We've used our 30 minutes up. I'd like to thank Jamie and Karen for being on Home Care Connection today. Thank you both. Remember, If there's a topic on healthcare that you'd like us to tackle and you want more information on our services, please call us at 802-775-0568 or email us at RAVNAH at info@ravnah.org. I'm Harry Snyder. Thank you for joining us on Home Care Connection.